this episode of The Natural Plastic Surgeon.
Is this a board certified plastic surgeon? Okay. By the American Board of Plastic Surgery. There's a big difference there. There's other boards that are out there. Some are fictional, they don't exist. Some are made up, like the American Board of Cosmetic Surgeons. That was made for people that never were board certified by the American Board of Plastic Surgery. You have asymmetry. If you have any breast asymmetry, sizing is a must, because sometimes people have a 25 cc difference, sometimes people have a 50 cc difference, and you will only be able to get that right in the operating room. Capsular contracture is a big thing that we're trying to prevent with all the things that we're doing in surgery. So what I noticed when I started doing the inframammary incision is that scars were way noticeable. Patients weren't happy with it. Bottoming out happened. There's no studies on bottoming out, but there should be. That's where implants drop below and they fall exactly where they came in, right? If you put an implant from the bottom, guess where it wants to go? It wants to go out the way that it came. Hey everyone, you're watching and listening to the Natural Plastic Surgeon podcast. I've got a special episode for you guys today. Today we're going to talk all about breast augmentation. And the things you need to know. We're gonna pack it all in. We're doing a solo episode just so I can get all the pertinent information. So you guys are in luck. Get excited. You're gonna get a lot of information coming at you really fast. Okay. So I get a lot of questions about breast augmentation. As you know, I'm Dr. Barrett. I'm a board certified plastic surgeon here in Beverly Hills, and I specialize in breast, body, face, and nose plastic surgery. More importantly, I do about 6 to 9 breast operations every week. And so I get a lot of people coming in. I get a lot of people writing in or calling in asking about breast augmentation. What do they need to know? What do you need to know? And so I wanted to do this episode to kind of go into it so that you guys know exactly what you should need to know before starting your journey. If you're considering it, or if you decide it's not for you, that's fine too. So one of the questions I get is, where do I start with my research? How do I start this process? Well, there's a lot of information out there on the internet, and there is a lot of good information. There's a lot of bad information. And so what I suggest is to look up a board certified plastic surgeon, find someone who does a lot of breast surgery. Okay. Someone who does at least 1 or 2 breast operations every week. They have before and afters so that you can actually look at the results, look at the quality of the results. Does that speak to you in terms of what you're thinking of in terms of your goals? So at the base of your research pyramid should be, is this a board certified plastic surgeon? Okay. By the American Board of Plastic Surgery. There's a big difference there. There's other boards that are out there. Some are fictional, they don't exist. Some are made up, like the American Board of Cosmetic Surgeons. That was made for people that never were board certified by the American Board of Plastic Surgery. Not the same caliber. To get board certified by the American Board of Plastic Surgery, you have to go to medical school, you have to go to a qualified residency. Then you have to take lots of tests, and you have to submit surgeries that you've done. So it's a very detailed process, and it really selects the best of the best. So starting right there, that's the base of your research. Next thing, find out more about these particular surgeons. Find someone local if you can. If there's nobody local, find someone who has a visiting program so that you can come and visit the plastic surgeon, get everything taken care of, and there's still a resource for you when you go back home. We have that set up here in our office with virtual consultations, and we have a lot of out-of-town patients that come here from all across the world. Next thing you want to do is, like I said, look at those before and afters. Do the results really speak to you? Is this a look that you're trying to achieve? Are the results really big and fake looking? Is that what you want? Or are you looking for more natural looking results? So those are things you want to kind of look at. Lastly, I would look at reviews. Here in Los Angeles, Yelp reviews are really important. They're really big. You can't make them up. They're very strict, unfortunately, about their review guidelines. So if there's a review up there, there's no way it's coming down. So even our practice, we get bogus reviews. We get some real ones, and it's a great way to really hear what other people are saying. I don't know how it is in the other parts of the country. Yelp is not as big in other places, but there's other sites like Health Grades, Real Self, Google. All of those reviews you wanna listen to and pay attention. And guess what? You can also reach out to those people that wrote reviews and you can ask them, hey, did you really write this review? Was this really your story? Can you tell me a little bit about more Dr. Barrett or whoever, Dr. So-and-so? And then I would call the office. By the way, backing up now, you can also check out their Instagram profile. What do they do on social media? Not every doctor does social media. I do a lot of social media because I want to be transparent. So I put it all out there. So viewer discretion advised, okay? So if you do check it out, be mindful that I will be showing graphic details of surgeries just so you can see exactly what's involved. I want all my patients to be fully informed about surgical decision-making process. So you're going to see everything there. So you've done your Yelp research, you've done your review research, you've done your social media research. Now call the office. Do you get a warm person on the phone that answers, or do you get a automated response? That's going to be your first clue as to whether or not this is going to be a place you want to go get surgery done on your body. Okay. You want a place that's going to be there for you in case you have complications. That's easy to schedule, that doesn't make you wait, and that's friendly and can provide valuable information on the phone. So that's something that we always try to do. So that's where I would start. Next question is, how do you get natural looking breast augmentation results? So I mentioned to you guys, that's one of my core philosophies in my practice. I'm from Virginia. I have an organic garden in my backyard. I have a beehive. I'm really into natural looking things, form and function. I never want to make somebody look fake or unnatural, that they couldn't have been born that way. I think there's natural versions of bigger that we can achieve through breast augmentation with implants or with fat transfer. And my goal is to make it look like you haven't had surgery, get you the results you want, but make it look like you haven't had surgery. So how do I do that? Well, there's a lot of things that I do. The main thing I spend most of my time on is pocket placement, getting that implant partially underneath the muscle, and a kind of, the pectoralis muscles when you do push-ups, whatnot. And so if you are to place the implant partially underneath that muscle, so actually maybe we'll show you on this side. Implant partially underneath the muscle creates more of a teardrop shape versus that fake and rounded look with the implant above the muscle. I call that the $5,000 Vegas special. You see it on the billboard on the way to Vegas, and you see it at the pool parties, the results there. That very fake and rounded look on the top. You definitely want that submuscular placement. All right, so that's step one. That's where I spend about 65 to 70% of my operation, is getting that perfect pocket placement. Next, I spend a lot of time on my closure. I close in 5 layers, which is insane. It's super OCD. But what we found is that when you were able to bring all of those layers precisely back together, you get much less scarring. Okay. And lastly is size choice. Okay, there's a lot of things that go into determining size. We'll get to later in this, but you want to pick a size that's customized for your body. You want a surgeon that sizes you in the operating room with sizers. It's like trying on a pair of shoes before you buy them. Yes, you can buy online, but you don't want to commit to buying that until you actually try them on. Okay, so that's how you get natural looking breast. That's how I get natural. That's some of the main components of how I get natural looking breast results. Because again, my biggest fear, and this is the truth, is that I don't want any of my patients to go to the pool party or go to the beach or be with their friends and family, and someone's like, "Oh, she's had a breast augmentation." Okay, then I feel like a failure. So that's how I design the whole operation. Okay, next question. Will breast augmentation affect nipple sensation? I actually had this question today. I had about 8 consults for breast surgery today, and that's a great question, because nipple sensitivity is very important. It's very important for arousal, just general well-being, and so forth. If you understand the anatomy of nipple sensation, you can understand the answer to this question. The nerves for nipple sensation, they come from the spine, right? All of our nerves come from our brain. They go down behind our spine and they wrap around our chest and they poke out a muscle called the serratus anterior. That's a muscle that is kind of like those like that ripped, if you ever see those people that ripped look right underneath the armpit, those kind of looks like 3 or 4 little cords there. That's the serratus anterior muscle, and the nerves for the nipple sensation, most of them wrap around and they percolate through that muscle into the pectoralis and then right directly underneath the areola. So the way that people lose nipple sensation is when surgeons do lateral dissection of the pocket. That is, they create a pocket and they dissect too far to the lateral aspect. It's a great way to speed up your operation because you can make a room for a quick implant, very large implant by doing that. And it's something that I never do because if you go inside and you look in there, you can see those nerves popping up through the muscle and you have to protect them. That's why my loss of nipple sensitivity is very rare. I can count on one hand how many times I have had patients lose nipple sensitivity. And these are patients that typically go very large or they're revision type procedures where there's a lot of work that needs to be done. So it has actually nothing to do with incision placement, whether you go perirelar, inframammary, or transaxillary. Transaxillary has the highest risk of loss of nipple sensation because guess what? You're taking an implant, you're going through the armpit, and you're directly going across where those nerves travel, right? So that's why I typically avoid the transaxillary. I can do it. That's why I avoid the transaxillary incision, and I stick to the perirelar or inframammary incision, which you can see in this friendly diagram here, okay? So that's nipple sensation. So most people, they don't lose it, but I will tell you this. If nipple sensitivity is the most important thing to you in the world, do not do breast surgery, okay? Because nobody can guarantee that you will keep your nipple sensitivity. In fact, most of my patients, they actually get hypersensitivity for a while as things heal, and then it goes back down to normal. But again, this is one of those things that can happen with surgery. So if it is the most important thing to you, it's very important to you, don't consider breast surgery. Okay, there's pros and cons to everything. Now, how do I determine size? I mentioned that briefly. Sizing is one of the most challenging things that I do, that I get to do for patients. And it's one of the most difficult things to do right. A lot of us have heard horror stories about, I went to this doctor, I woke up and I had double D breasts, or I had like 450 cc high profile implants. I just wanted a B cup. And I feel like those are all true stories. And sadly, that happens because there is a disconnect of when the patient talks to the doctor and the doctor's not listening, or the patient's not clear on their goals and there's a loss of communication. You absolutely have to establish clearly what your goals are. If you don't communicate that clearly, you're not going to be certain about what your ultimate size is going to be. The way that I like to do it in my office is a result of tried and tested ways that I've kind of evolved over time. When I first opened my practice, I started using sizers in the exam rooms. I'd have patients put their bras on. I would put the sizers in the bra and be like, okay, 325 looks like it's going to be right for you. Go to surgery, put it in. Most of the time it worked. I'd say 80%, 85% of the time it was kind of in line with what they wanted. But about 15%, 10 to 15% of the time we'd put it in and I'm like, oh, it's kind of too small compared to what we were talking about. And I didn't like that. So I started getting away from that. I've tried computer animation, 3D animation with dedicated photography to simulate breast sizing results. There's a program out there that does that. And that was about the same rate. And so lastly, the third way in which I do now exclusively is I size patients in the operating room with sizers. So it all starts with the consultation. I get a really good sense for what your goals are. What are you expecting? We do talk about bra sizing, but it's subjective, right? Victoria's Secret is different than JCPenney. It's different than Neiman Marcus. So there's no golden bra sitting in the British Museum, right? They have a kilo, they have a pound, or whatever. They have they're not on metric. They have the golden pound or whatever it is, and there's no universal guidelines when it comes to bra sizing, and that's why it's so difficult to talk in terms of bra sizing. We all get a sense for what a C cup and what a D cup is, and that's why I do talk about it a little bit, but I try to get the conversation away from that. I try to get it to photographs. What are some photos of sizes that you like? Let's check out ratios of breast width versus shoulder width. Do you want the breast to stick out a little bit outside the chest wall? A lot? Do you want a lot of side boob? Or do you want just a little bit? You want it to be completely within the chest frame, okay? Those are some concepts that you have to kind of internalize for what you want for yourself. Because if you can't find photos that really speak to you in terms of what your goals are, how do you expect your surgeon to match it? Okay, so you have to do some soul searching. What do I really want? And I get a lot of patients that are like, you know what, I was told that I should go bigger. I was like, well, what does that mean? Because there's a point where it's too big. So it's just like, fine, you know what? Screw that. Screw that advice because I think it sucks. Spend the time, do your soul searching, do a lot of searching on one day, sleep on it, go back to your top 3 picks of that previous day, look at it again. Do one more day, look at it again. You're about to undergo surgery in your body for implants that are going to last about 10 years. So you want to make sure that you get this right and that you're really happy with it. It's tough because how do we know what decision to make? I promise all my patients I keep them within natural looking results. Okay. We do measurements in the office, and measurements are important. One of which is we do is called a base width measurement, one of many. And if you measure your chest width right here, okay, I have my tape measure with me, that's that noise. My base width is about 17 centimeters. Okay. So 17 centimeters, I need an implant that's about 17 centimeters wide and a diameter. So if you were to actually measure the diameter of an implant, like this one, for example, is about 13, this implant would be too small for me. Okay. One day it'd be over here, the other day it'd be off on the other side. So we need to find an implant that's within a centimeter of whatever your base width is. And that's typically about a 200 cc range. Okay. So that puts us in the ballpark of what you need. And then the remainder we take care of with your photos and sizing in the operating room. So let's take that 325, let's put it in. Your measurements say that you're, 325. We think, you kind of want to be in mid-range in terms of photos. Let's put it in there. Let's see exactly how it looks. Because sometimes you think you're a size 7 in a shoe. You go to the store and you're not, like a 7.5, right? So shoes you could throw away, right? But breast implants, you need another operation if you're not happy with the size. So that's why it's even more important that you do your soul searching on this, your meditation, whatever it is, figure it out, because if you find those photos that really speak to you, it makes this process way more effective. And I found it to be the most successful way of getting people exactly the size that they want. And that's really important to me. It's not what I think. I customize every operation based on my patients, and I will make sure that it looks natural. I'm not going to do something that distorts the natural body or anatomy. But there's a range that I can go. I can go on the smaller side, or I tell people I can go on the bigger side. So it's important to do that soul searching, that sizing. And then if you have asymmetry, if you have any breast asymmetry, sizing is a must, because sometimes people have a 25 cc difference, sometimes people have a 50 cc difference, and you will only be able to get that right in the operating room. And sometimes you have breast asymmetry, but then there's a rib cage elevation that's different, and what you think might be a different size, you put in the same size, it actually looks better. So if you see my operations on my social media, drdanielbarrett.com, you will see how I do that sizing on every single operation. Is the most critical part of making sure we get the right size. Okay, so what implant options are there? So I have all these implants out here with me. I'm here in my operating room, on the operating room table that I do a lot of my surgeries. And I've got textured implants, I've got smooth implants, I've got saline implants, and let's talk about each one of them, okay? So first decision you want to make is whether you want to go silicone or saline. Silicone is cohesive gel now. It's called gummy bear. They're all gummy bears. So if you were to cut it, the gel doesn't run off the table and into your body or wherever else. Okay, they're cohesive. They're like gummy bears. They don't rupture very much. They're pretty high quality devices, and exposed cohesive gel silicone is minimally problematic for your body. Okay, so even if there's a rupture, it's not a huge deal. Okay, your body typically walls it off, and in my opinion, these implants are extremely safe. I wouldn't hesitate to use one on a family member. Okay, you have saline. Saline is another option. They are filled with saline, and they feel more like water balloons. They don't feel as natural. They don't feel like breast tissue. They have rippling on the sides. If they rupture, you know right away. Saline is not really toxic if it leaks into your body at all, but the shell is actually made of silicone. So I don't really see the advantages in terms of using a saline implants other than cost and keeping the incision maybe just a tiny bit smaller. Saline implants typically are a little less expensive, but if you're about to get surgery on your body, why not spend a little bit extra and get the better looking implant and the more natural looking implant, because saline is not the solution there. So it's been a while since I used saline implants. I just don't think there's any advantages to it. And most of my patients that come here are not bargain hunters. There's two things you don't want to bargain shop for: parachutes and plastic surgery. Okay, guys. So let's put saline aside. Now, when it comes to silicone implants, we have textured, we have smooth implants. There's been a lot of, I have a whole episode talking about textured implants and the incidence of anaplastic large cell lymphoma. The risk of that in Mentor implants textured is about 1 in 86,000. There's a recall with Allergan textured implants. It's 1 in 3,000 risk of anaplastic large cell lymphoma. That's a rare lymphoma that can happen due to bacterial contamination on the textured implants that develops inflammation over time. If you want more information on that, check out my podcast with Dr. Chopra, where we talk all about that, okay? What applications we use textured implants for are for lifts, very heavy lifts, or revisions. Okay, the main reason why is because the texture of the implant is very grippy. It stays where you put it. It's great for really challenging cases where you need stability of the implant in the pocket. Okay, and I do get some of these pretty gnarly cases where we pray for that stability, right? And we've had several people here discussing that we've used textured implants. Okay, so you can check out their story. Skinny Confidential. Lauren Everts is very publicly known, and she had textured implants for that reason, because she needed stability of her breast pocket after bottoming out. Okay, and again, your chances of getting struck by lightning in your lifetime is about 1 in 3,000. Your chance of getting anaplastic large cell lymphoma, which is treatable, by the way, is 1 in 86,000. Okay, so you have to put those statistics in mind. Okay, now when it comes to smooth implants, there is shaped implants, and there are there are shaped implants and there are round implants, whether or not they're smooth or textured. Shaped implants, they're called teardrop implants because they look like a teardrop, all right? And I first started using these when they first came out, and I thought they were great, but they rotate, okay? When they rotate, they cause problems. They have about a 30% rotation rate, and even if they are textured, and they tend to be firmer, and you tend to lose cleavage in the middle. So I've really only felt that the applications for these are for women who've had mastectomies. I don't see the advantages of using these in primary breast augmentation. They're really hot for a while. For a couple of years ago, people thought, oh, it must be better because it's shaped like a breast. Well, in reality, it ends up causing more problems. It ends up looking more pronounced on the bottom, kind of like a boomerang on the bottom, and wasn't very natural. So I kind of stopped using those for primary augmentations. What I do typically use mostly for primary augmentations is smooth round implants. Okay, so let's get textured off the table. Okay, so we're not doing a lift, we're not doing revisions, we're not doing shaped implants because you didn't have a mastectomy. All right, so now we have smooth round silicone implants. What are the options there? Well, there's three companies out right now that make implants. There is Mentor, and there's Allergan, and there's Sientra. I like to use Mentor implants because I think they have the best warranty. They have smooth, very soft, pliable texture. They tend to feel a little bit softer than Allergan implants. But all three of those companies are actually really good. And so I don't think you're going to go wrong. Where I do like to make a decision, though, is about the profile of implants. So there's high profile implants, there's moderate profile implants, and there's low profile implants. I barely ever use a low profile. I've used a couple of them and they look like pancakes. I stopped using them because I wasn't doing anybody any favors with a low profile implant. So I've mainly gone from, I mainly actually just use moderate profile plus for my augmentations because it tends to look more natural. What is projection? What is profile? Profile is the amount of projection for width, right? So think of like, a skyscraper as a high profile implant, right? That's very tall but very narrow. And then think of a moderate profile implant as kind of like a pyramid, right? Big wide base, some projection, some height. And I like to use, like I said, I like to use moderate profile for most of my augmentations for a lot of reasons. Because what I found is that using high profile implants creates a big gap in the middle, a big cleavage gap. Yes, you get that really nice projection, but that tends to look fake, right? So we don't really want that. We don't want that fake look. And the other thing is, if you understand physics, force per unit area, how much pressure is going on per square centimeter in the bottom part of this implant, it's much higher on a high profile implant versus a moderate profile implant has this kind of smooth, gradual hammock on the bottom that evenly distributes that pressure. Okay, so you get much less malposition with moderate profile implants versus high profile implants. High profile implants tend to fall off to the side a lot more, and they don't stay in place. My biggest revision rate for other people's plastic surgery augmentations are high profile implants with an inframammary incision, right? Because you just made an incision right where you need that support mechanism of the breast, and you put a high profile cannon right on top of that incision. And guess what? It's going to hammer that incision, that opening, over 2 to 3 years. It'll start to drop, it'll bottom out. How do you know you're bottomed out? The implant drops and your nipple points to the sky. Okay. So I could actually do a whole episode on implant options, but those are the main things that I like to talk about during a consultation. But we can certainly talk about more. We'll save that for another episode. Now, another question we get, what affects the nipple sensation in terms of incision? So we talked about that. We talked about the anatomy. There's no difference in periareolar incision and inframammary incision. However, there is a higher loss of nipple sensitivity with a transaxillary incision. You have just to understand the anatomy for why that works. What incisions should I use? Now, this is a very hotly debated topic, okay? There are 4 main types of incisions. So transaxillary, periareolar incision, inframammary incision, and periumbilical incision. Okay, periumbilical can only be used with a saline implant. That's why I virtually never do that. The other 3 can be used with saline or silicone. Transaxillary is through the armpit. Periareolar is on the bottom border of the areola, which is right next to the nipple, and inframammary is at the breast crease. Okay. In terms of, let's go through the pros and cons of each. Transaxillary incision, one of the most noticeable incisions, because you can see it if you raise your arm up. It tends to scar badly because the armpit doesn't heal very well. There's a chance for contamination through the armpit. It's not the cleanest place. It's really even hard to get clean during surgery. The implant, if you remember this, the implant likes to come out the way you put it in, right? So if you go through the armpit and you come in laterally, guess where it wants to go over time as you heal? Laterally, right? So you get the most amount of lateral displacement with transaxillary implants. It takes a really good surgeon to do transaxillary augmentations well, because you have to do everything, all your whole pocket dissection through the armpit, through an awkward angle, all through a tiny little incision. So it can be done. It's just really, really challenging, and I see a lot of complications from it, and I do a lot of revisions from transaxillary, okay? So it's not one I recommend. Now, let's talk about the next one. Inframammary incision. That's an incision that goes on the bottom part of the breast crease and is probably the most common incision used. In fact, when I first started my practice, I used that exclusively because I felt like it would reduce my risk of capsular contracture, and I thought the incision was concealable and it would heal well. Well, welcome to Los Angeles, where there's all types of people here. You know, Fitzpatrick skin types, all types, right? So Fitzpatrick types 1, or these are the redheads or the Swedish people, they have light skin and blonde hair, and guess what? It doesn't matter really where you make their incision, they're going to heal fine no matter what. Majority of my patients have Fitzpatrick 2, 3, 4, and 5, right? So they are going to have much more noticeable scarring. So if you're going to make an inframammary incision, you have to counsel them and let them know that if they were to wear a bra or a bikini, you're going to be able to see that line on the bottom part of the breast. Okay, so it is not very concealable. Now, there has been some studies that show that there's a decreased risk of capsular contracture with inframammary incision. Capsular contracture is a very important thing to understand. We'll get that get into that in a minute on one of these other questions. It's basically scar tissue formation that can happen around the breast implant that happens due to contamination. Capsular contracture is a big thing that we're trying to prevent with all the things that we're doing in surgery. So what I noticed when I started doing the inframammary incision is that scars were way noticeable. Patients weren't happy with it. Bottoming out happened. There's no studies on bottoming out, but there should be. That's where implants drop below and they fall exactly where they came in, right? If you put an implant from the bottom, guess where it wants to go? It wants to go out the way that it came. Okay, so I started studying the peri-realar incision, and now I use that. I recommend that the most. And again, anybody wants any of these incisions, I'm happy to do them, and I can do them well. But I think the one that has the most advantages is the peri-realar. So how did I address the capsular contracture question? Because there was a significantly higher percentage of capsular contracture with peri-realar, possibly due to contamination from the breast glandular tissue or the ducts getting on the implant somehow. Well, I was the first person in Beverly Hills to start using the Keller funnel. You want to make sure any doctor that's doing your breast augmentation is using some kind of funnel device. A funnel protects the implant as it goes into the breast pocket. I do no-touch technique. I irrigate with antibiotic solution. I get meticulous hemostasis, all these things that help reduce capsular contracture rate. So nationwide, the capsular contracture rate for breast augmentation is about 20%. So it's about 1 in 20, so about 5%, okay? Right now, my rate going through peri-realar is about 1 in 100. So I've effectively been able to use a peri-realar incision, decrease my bottoming out rate, decrease my noticeability of scarring, and decrease capsular contracture rate, right? So that's why I recommend the peri-realar incision, because you have to be completely naked in order to see that incision. And guess what? Chest wall tissue is not designed to handle trauma, right? Your nipple and your areola is much more designed to handle trauma for breastfeeding, right? So it heals predictably better. There's a natural color border that happens in the border of the areola with the rest of the breast tissue that makes it the perfect concealable location for an augmentation. Okay, and I've never had a nipple or areola that was too small to do it. A lot of surgeons like to still do that inframammary incision because they believe in that capsular contracture reduction, and my hat's off to them. That's totally fine. I think that's very noble. But my patients here in Los Angeles with different skin types, it isn't the best concealable option for them, and that bottoming out rate is just unacceptable. There should be 0% of that happening. So. Great question. Oh, the other sneaky thing about the inframammary incision is that it's faster to do. So surgeons get really easy to used to doing that inframammary incision because it's super fast to do that augmentation. It's much harder to go through that border of the areola to get that perfect pocket placement, okay? But I do it because I think I get better results from it and happier patients. All right. Again, I feel like I could talk about all day about incision, and but those are some things I talk about during my my consultation. But every surgeon's different, and again, if you're going with a board certified plastic surgeon that does a lot of this and has really good pictures and before and afters, go with what they recommend. Okay, but that's just how I do things. All right, so I do want to talk a little bit about capsular contracture because I just briefly mentioned it. Again, it's that scar tissue that forms around the implant. We don't really fully understand why. We have a feeling that has to do with contamination, but there's some people that there's probably no contamination that still get capsular contracture. There's some people that are higher risk for it. We don't fully understand it yet. We're definitely studying it. I do about 6 different things to prevent capsular contracture during my operations. I use the funnel technique, a no-touch technique. I change gloves. I get meticulous hemostasis. I irrigate 3 times with triple antibiotic solution. I re-prep the area with betadine so that I don't, in case something falls from the air, lands on the access site, that there is very little chance of getting contamination during my operations. So what happens if you get capsular contracture? Well, you can treat it medically with a medication called Singulair or Accolade. These are basically, they're not antihistamines, but they are kind of allergy medications. They're leukotriene inhibitors that act selectively on certain pathways. So what they found is people that were taking it for their allergies noticed that if they had capsular contracture that they just didn't want to treat, reduced. So that's where we like, hey, just a heads up, my capsular contracture went away. So that's how we discovered about these medications. So if one of my patients gets capsular contracture, I start them on the Singulair or the Accolade to get a reduction of that. And a lot of times that works. If it doesn't, then you need to go back to surgery to get a complete capsulectomy and start over. Now, one of the questions I get is, should I go above or below the muscle? Going below the muscle is by far one of the best routes to go because it looks way more natural for that teardrop look that we just previously talked about. And it also reduces your risk of capsular contracture. The drawback of going underneath the muscle is you get a slight bit of animation deformity when you flex your muscles, and that's normal. But most women get used to that and they just They don't end up, I mean, most women are not out there flexing their pectoralis muscle. It's just not something you would do anyway. So they kind of get used to that so that they understand what triggers that animation, and then they don't do that and they relax that motion. But hands down, their breasts look 10 times better, 10 times more natural than if you were to go above the muscle. There's few instances where above the muscle makes sense, but most of the time for primary augmentation, you want to go partially underneath the muscle in the dual plane technique. That's pretty well known at this point. Now, what is the chance of getting capsular contracture? I told you this nationwide is 1 in 20. My rate's about 1 in 100. I'm actively studying this. Try to make it 0. I want to make it 0, folks. I don't want people to get capsular contracture. It's the biggest number one complication that I have in my practice, that most plastic surgeons have in their practice. And it should be, we really are trying to eradicate it. Any good plastic surgeon should be doing all of the published things that are out there to help reduce it. Funnel, irrigation, changing gloves, all that good stuff. And those are great questions to ask at your consultation. Okay, so breastfeeding. Breastfeeding is a very popular question that I get. Women who are younger, they haven't had kids yet, or they want to have more kids. They're like, does it affect my ability to breastfeed? Now, there's a bunch of studies out there about breastfeeding ability. It's important to understand that some women can't breastfeed no matter what you do, and whether you have implants or not. Some women who've never had implants have difficulty breastfeeding, and they just can't. So women who have had implants and can't breastfeed, they sometimes blame the implants for causing them not to be able to breastfeed. When you actually break down the statistics and you look at it, breastfeeding ability, statistically, when it was narrowed down, is shown to affect breastfeeding ability anywhere between 7 and 15%. And it's important to know anatomically, the implant is sitting underneath the muscle, right? The glandular tissue is above the muscle. So when you think about it anatomically, the implant's farther away from the glandular tissue. A lot of people are worried about, is there going to be silicone in my breast milk? They actually did a study on that too. They found more silicone in women without implants in their breast milk than silicone in women with implants. Isn't that crazy? So it goes to show you that the silicone doesn't really bleed. The old ones way back in the day, 30, 40 years ago, did. They had a high bleed rate. But the newer implants, the studies do not show that you're actually leaking out silicone or anything like that to potentially contaminate breast milk. So I have no problems with women breastfeeding with implants, as long as they're recent implants, they're not old, and they're not ruptured. Okay. So what? Let's see. One more thing I wanted to tell you about breastfeeding. Is the same thing with nipple sensitivity. If breastfeeding is the most important thing to you in the world, it's very important. Don't do breast surgery, okay? Because yes, there is a statistical significance of 7 to 15% of women report difficulty breastfeeding with implants. Okay, so it's very important that you weigh that risk. It doesn't prevent you most of the time, but if it's a really important thing for you to do, don't do breast surgery. Okay. Now, my route for placing implants is very protective of the glandular tissue. I kind of skate around it when I make my incision. I'm not going behind the areola. I'm not going behind the nipple ducts. Breastfeeding is very important to my family, and that's the last thing I want to do is set my patients up for a higher risk of difficulty breastfeeding. So anatomically, in my surgical route, I try to avoid all the glandular tissue. Okay, but I can only tell you statistics nationwide. I don't have statistics on my own patients and their ability to breastfeed. I just don't have the numbers. Okay. All right, moving on. When should I have my implants exchanged? We recommend 10 years. Okay, the rupture rate stays pretty baseline until about 10 years, and then it goes up exponentially. It's like driving on tires that are meant for 50,000 miles, but you're driving on 55,000 miles or 60,000 miles. Okay, you probably can get away with it, but you don't want to risk it. Will my implants make my breast sag over time? Yes and no. Statistically speaking, if you go up to 400 cc's, they don't really create a problem with sagging until you go over 400 cc's, and then complications for breast sagginess start to develop. Okay, so my recommendation is I try to keep people 400 cc's or lower, because the statistics say that over 400 cc's you start to run into problems with that. I mean, it makes sense. Implants are not very heavy, but at a certain size, they are going to have an impact, especially if you're smaller framed. You want to keep within natural proportions of your body, keep within that 1 centimeter of your base width so that you avoid excessive weight on your breasts over time. Do breast implants cause cancer? The answer to that is no. It does not cause breast cancer. This has been well studied. There's been plenty of people that are trying to badmouth implants over the past 50 years, okay? And everybody wants to demonize them because of vanity and whatnot, and to each his own. But what they've never been able to show, and trust me, they've tried, do implants cause breast cancer? No, they don't. Sadly, 1 in 6 women get breast cancer for all kinds of reasons, but none of which are because of implants, silicone or saline. The one thing they did find was that association with anaplastic large cell lymphoma, which is not breast cancer. It is a lymphoma of the lymphatic system. It's a cancer of the lymphatic system that develops because of textured implants. And again, that risk is very, very low. 1 in 3,000 for the Allergan BioCell implants, which are recalled now, and 1 in 86,000 for Mentor Siltex implants. They're completely safe otherwise. So I actually had a couple questions from a consult today, and she was asking about breast implant illness. And I have a whole podcast with Dr. Chopra about breast implant illness, and I go into more detail about that. So breast implant illness, I think, is a real thing. I think it's pretty rare. Majority, 99% of the population are perfectly fine with implants. They don't have any problems, and implants are life-changing and game changers for a lot of women and confidence boosters. So there's more to be done on breast implant illness. Check out my podcast with Dr. Ritu Chopra, where we dive into it more, where we're actually trying to look and get statistics on breast implant illness. There's a lot of websites out there to talk about breast implant illness, and these are women that have real symptoms and real concerns, and it's definitely valid. But you have to understand this is a small fraction of people that get breast implants. It's not everybody. Other options besides breast implants are fat grafting. Okay, you could do liposuction in one area and then transfer the fat to the breast instead of an implant. The problem with that is fat's unpredictable. It waxes and wanes with body weight, and how much fat takes is totally variable. Okay, so we lose anywhere from 30 to 50% of the fat that we transfer to breast, and at most I get about a half cup size improvement typically with breast fat transfer. My home runs, I get about a full cup size, but those are rare. So I have to caution people that if you really want to do the fat transfer route, it might take more than 1 or 2 or 3 fat grafting sessions to get you to that size that you want. And if you're not looking for that, an implant is a perfectly good option, okay? Does having implants create chronic inflammation? Again, if they're contaminated, if you have a low-grade infection in there, that's why we do all this stuff to prevent, to have sterility. Probably not. But again, this goes back to the breast implant illness question, and we're actually trying to dive into further. For the majority of people, no. When we do surgeries to swap them out, their capsules are paper thin. There's no reactivity going on locally in the breast tissue. Is saline safer than silicone? Again, not necessarily, right? Because that shell of that saline implant is silicone. So what are you really saving yourself? Yeah, if it ruptures, you just get saline in your body. You're not going to get that cohesive gel, but that cohesive gel is much more cohesive than before, so that it doesn't actually run through your body. So it's much more localized if you were to get a rupture. What is a recovery period like? Well, I tell people for breast augmentation, it's about 3 days of solid downtime. Probably want to take a week off from work, depending on what you want to do. No heavy lifting for 6 weeks. My exercise regimen for after breast augmentation is as follows. Walking right away. I want you walking those first 2 weeks, getting the blood moving, circulation, but not getting your heart pumping to the point where you're out of breath. Okay, that happens at 2 weeks. You can start to do cardio. You can start to do exercise. That starts to pump your heart at 2 weeks. At 4 weeks, you can do jogging, where some bouncing movements. And at 6 weeks, you can get back to heavy lifting and lifting things and using upper body workouts, yoga, Pilates, and stuff like that. That's my recovery protocol. Now, everybody's different. So I tell people to use their body as a guide. If something hurts, don't push through it. Just let it heal. Take a day or two off and then get back to it. Okay. Has anyone had a crazy reaction to the surgery? Anesthesia is extremely safe. Okay, you're more likely to be struck by lightning than have a problem with anesthesia. I think the risks are like 1 in a million for a major adverse outcome for anesthesia, like death or major debilitation. So you're more likely to get in a plane crash, car crash on your way to the consultation. versus getting any problem with anesthesia. It's extremely safe. The monitoring we do here in an ambulatory surgery center, fully accredited surgery center, board certified plastic surgeons, is the same level, if not more, of what you would get in a hospital. Okay, so we don't cut corners when it comes to safety. We've got a perfect safety rating. And you want to find out, does your surgeon operate in an ambulatory surgery center, or do they try to do this in their office? If they try to do this in their office under local, chances are they're not board certified. I don't know any board certified surgeon that tries to do this under local. It is just a way too painful of operation to try to do under local. These people are kind of scams, and watch out for them. Make sure that they're doing it in fully accredited surgery centers using general anesthesia. It's really the safest and most comfortable way to go. Has anyone had a crazy reaction to the implant itself? No. These implants are mostly inert. You know, if you think about the hip and joint replacements that people get in their bodies, there's way more toxic stuff out there that's going on. Implants are pretty inert substances, products that are been proven safe by the FDA, countless studies. Okay. What are some of the most common complications for breast implants? We talked about the number one is capsular contracture. Okay, that's, for me, it's about 1%. Just underneath that, I have got hematomas. So patients that do heavy lifting or push-ups right after, or handstands. I had a patient, this is crazy. She did a handstand literally the same day of her breast surgery. Got a bleeder, hematoma. If that happens, it's no big deal. It's all self-contained, right? But you have to go back to surgery to get that blood out, okay? Get the blood out, stop the bleeder, put the implant back in. It's a double surgery, so you basically want to make sure you follow your guidelines. It can also happen without any particular rationale. If your heart rate goes up, or there's just something that wasn't bleeding during surgery and then started bleeding afterwards, it's a known complication. Infection is also a possibility. You want to make sure your surgeon gives you perioperative antibiotics. But infection can happen. Knock on wood, I've never had it. I've never had a full-on blown breast implant infection. I've had some local superficial stuff. Bad scarring can happen. Depends on your skin type. If you're a natural keloid former, we got to do certain things to make sure that you don't heal with thick scars or keloids. And implant rupture can happen. It's pretty rare right at the time of surgery, but it can happen. And I'm trying to think else. Wound breakdown and seroma can also happen. Those are much less common, especially with breast augmentation. What is a procedure like? Well, you show up. We try to make the process as painless as possible. Not only am I trying to perfect the surgery, you try to make the process here very smooth and effective. And that's why I say when you're finding that surgeon, make sure you talk to a real live person on the phone. You want to come in. You don't want to wait for your appointments too long. Literally within 15 minutes, you try to get everybody in here. I try to treat everybody how I would want to be treated. And that's how I design this whole practice for people. So we're not wasting anybody's time. Okay. You come in, if the day of surgery, you get no gown, you pee on a stick, make sure you're not pregnant. By this point, you've already had your labs done. You've been through, we've talked about photos, and we've done a consult and everything like that. And I do some markings in the preoperative area that help guide me during the operation. We go over your photos again. We go over everything else again, post and pre-op instructions. Repetition is key. Then you meet with the anesthesiologist and you kind of go over the anesthesia plan. We bring you back to the operating room, which is right here where I'm sitting. And obviously we do a terminal clean after we do these podcasts in here. But you come in, you relax, we start an IV, and literally once we get the IV, you are comfortable. And by the way, our anesthesiologists use numbing medicine for the IV. So even if you're nervous about that, there's a tiny little bit of numbing medicine we put on there. And so you don't even feel the IV going in, and you get some medication that will help you relax. And then the surgery starts. The surgery starts with me confirming my markings, making sure that everything is completely sterile, and numbing the entire area. I do 3 specific nerve blocks. I do the incision, I do the medial chest nerves, and I do the lateral chest nerves. So all the nerves that are going to the breast for sensation, I do nerve blocks on. That way, when you wake up, you just have a little bit of pressure from the implant itself, and you're not feeling very much pain. I also put a lot of numbing medicine inside the breast pocket, which you could see on some of my live surgery videos. I'm really careful because, who wants to wake up with pain? A lot of people are worried about that. I want to take that away from people. Most of my patients, they wake up with a little bit of pressure. So I do the surgery. Again, most of my time is spent dissecting the perfect pocket, sizing. I sit you up, check out sizers, compare to your photos, make sure we go up or down and correct any asymmetries at the time. We do our 5-layer. We get the permanent implant there with all the 6 different things we do to prevent the capsular contracture. We do our 5-layer closure. We cover with steri strips. We gently wake you up, clean you up, That's a big thing. I hate it when patients wake up and they have betadine or prep all over them. I get you cleaned up, and then we get you to recovery, and we're keeping you warm the entire time. I use normothermic pads on the bottom of the operating room table, and we use bear huggers in the recovery areas to keep you warm the entire time. Because what happens when you get anesthesia, your body can't thermoregulate. So we control your body temperature very precisely during the operation. A lot of places don't do that. I even got fancy IV warmers. So the IV fluid is exactly your body temperature. Okay, that's a big thing to help prevent wound infections too, by the way, but also makes you feel really comfortable so you don't wake up shivering after the operation. Then you wake up, you recover in recovery for about an hour or so, make sure that you're comfortable, and then we get you home. And you can go home right away, or you can stay at an aftercare facility or have a nurse take you to your hotel room. And I don't like prescribing Norcos or opioids for my patients. I do, but I recommend most of my patients take ibuprofen or arnica after their procedure. Most of them do not need to have opioids because of all the pain blocks that we do in the nerve blocks. Okay. All right. So we are getting down here. Recovery time. We talked about it. 3 days solid downtime, 7 days relative recovery time, 6 weeks return to full activity. And if you do have children, you don't want to lift them up for that first 6 weeks. If you're coming to visit me out from a various location, different country, different state, I like to have you here at least for 5 days so that we can get your first layer of stitches out. If I can, a second post-op visit is great. And I always tell people, if you come out to see me, plan for an unexpected problem that you might have to come out one more time for us to take care of a particular complication. Because if you plan only for one visit and something happens where you need to come back out again, then and you didn't plan for that, then you're kind of bummed if that happens. Majority of my patients, they go home, we follow up on Skype, and we don't have any issues with that. Okay, you guys, so we got through all these 30 questions, and if you guys have more questions, check out my website, breastbybarrett.com. I've got a lot of myths. I got a lot of before and afters up there for more information about that. Also, if you are on my YouTube, feel free to leave your comments, questions, feedback right here on my YouTube page. And don't forget to subscribe if you want to see more videos like this. And obviously, if you're on the podcast, you can shoot us an email, info@Barrett Plastic Surgery. If you have any questions about breast augmentation consultation, or setting one up, you can email us, or you can also give us a call, 310-598-2648. You guys, thank you for listening to this. I know it was a lot of information. You can play it back on slow so you can get all the details and all the information that you need for your breast augmentation surgery, and good luck.